So before we get to Travis, I want to talk about the reason that I brought this set of scales here. A lot of the time when we work with babies, we talk about, the literature talks about, we want to use 2 newtons of force. 2 newtons of force is 10 times underneath, just as we were saying just now, 10 times underneath that safe limit. We want to be able to use that. Now, I remember sitting in a seminar and going home and going, what is 2 newtons of force? How do I know what I'm supposed to do? And then work with a very good mate of mine in Australia, and he's got this amazing like touch pad that shows you how much this and how much pressure you're using and what have you. And then I thought, well, hang on a second, I'm sure I can do that in an easier way. And I'd like to, you know, guys at home, grab out your scales, and this is how you can check. 2 newtons of force is 200 grams. So if you get onto there, and let's just set that to the right place. There it is. Oh, no, I've now missed it. There we go. Getting down to that 200, that is, yeah, give that a go. You give it a feel. So you just want to get to that 2. Yeah. There you go.
Okay, yeah.
Yeah, there you go.
Okay, the wrong scale.
Yeah, so you get that feeling of that's the kind of pressure that you're going to hold on. But there's a better thing to show with this, because a lot of people will like to do a little bit of a flick, a little bit of an adjustment flick at the end. The problem is force is mass times acceleration. So this is a really nice thing to do at home to check. Get yourself down to that 200 and then do a little flick. And it shows you how far that actually goes. So give that a go and just give it a tiny little...
It's going massive. Ah, right.
So there lies the problem. When you are going to give a little flick at the end of the treatment, you really got to know what you're doing, because the force that you're applying can be a lot bigger.
Now, it's interesting you said that. I mean, it wouldn't have occurred to me that people do apply a little flick to small creatures like this.
So one of the problems we have is that, anyone within the profession can say, I want to start seeing a child. They haven't maybe done work on children. This is why our work is so important, to be able to go, they're not just little big people, morphologically, physiologically, they are different. And they require different amounts of input. The same as you don't just give them a 1/10 of a medication because their glomerular filtration rate's different. So it's not just about less, it's about how long do they take to get it out. And the problems we have here is that the cartilage that they have, when we say babies are made of cartilage, it's not adult cartilage, it's baby cartilage. Again, it has a much lower resistance rate. So again, what we know, and from people like the wonderful Aurélie Marchand, who's done fantastic research on this, we know that that's safe. So what's nice is if that's the pressure that you're using, you are within the literature.
Yeah. Now, how often, I mean, under what circumstances would you want to apply that sort of technique, that sort of flick, or what I would call a high velocity technique to an infant?
So that, if we look at our safety margins, and these have been documented, so we know none of that happens with infants. That only starts to happen way later into development. And if we look at a child at about 8 is the magic number. Now, 8. It's not about age, it's about stage. So it's your general developing 8-year-old. Because, development has to do with you going through the environment. So if you have a child that doesn't, like a cerebral palsy child, is going to have a very different morphology than, so we're talking about your neuronormative 8-year-old. That's when we have more of an adult situation, and that's when we can start looking at changing up technique. But again, that's not a technique that you want to be employing straight away. And I think something like showing that goes, that's why I don't want to employ it, because it's not just a little bit more, it can be a lot more.
Right. I'm reassured now.
Oh, good.
I got the impression you were saying that, it's okay to do these as long as you keep the pressure low. Right, good.
With that, the whole idea is to be able to show that's how far that can go, and to be able to show, first of all, we don't need that, because we've got, the research that we have done is on touch and hold, which is what we're talking about there, that kind of pressure. So the research out there is on that kind of, those kind of movements with babies, and that's where we keep it.
Right.